Hello, I'm Ed Draper and thanks for watching. When I first became a paramedic, I was fascinated with how more experienced medical professionals could come up with a differential diagnosis for the patients they were treating. They'd ask a few questions, they'd assess the patient, they'd run a few tests, and ultimately they would determine what the problem was with the patient. I knew this was simply a matter of knowledge, heuristics, and experience, but I knew that in order to be successful, I had to find out how they were doing it so quickly. I was working for a rural ambulance service and worked with a physician who was very committed to the growth of the paramedics that worked with him. And one day, after having a conversation with him, it finally clicked. Patient assessment, no matter what the discipline of the provider is a process where they weigh out each of the possibilities for suspected illness in order to make an educated patient care plan with the resources and the information that we have on hand. This is where I came up with what I like to call the basket theory for differential diagnosis. The principle behind it is pretty simple. You take the signs, symptoms, risk factors, history, family history, the medications, and the story for the current illness, and you metaphorically place them in baskets for the potential conditions that the patient has based on their complaint. Ultimately, the heaviest basket is what you use as your running diagnosis, and that's what you use to create your initial patient care plan. So how do we apply this? We've each had the patient with which we struggled to determine whether the patient was experiencing an exacerbation of COPD versus the CHF patient. Using the basket theory, you would take the signs, symptoms, risk factors, history, story for each of the associated illnesses and put it in their respective baskets. The heaviest basket is what you use for your running diagnosis. Signs that might help you differentiate between the two would be wet versus wheezy lung sounds. The CHF patient would probably have edema, pursed lip breathing, hepatojugular reflux, and possibly an S3 heart tone, versus your COPD patient, which is a barrel-chested patient who has a productive cough and gray periphery. The symptoms, that's where it gets to be a little challenging because they both have fatigue, they both have exertional shortness of breath, and some sort of cough, which ultimately makes it tough to determine the difference. So then you can move on to the risk factors, which heart attacks, hypertension, heart valve problems might lead you towards CHF, while a smoker who is prone to chronic bronchitis might lead you toward a CHF patient. If you look at their history, a patient who's had heart attacks in the past or some type of coronary artery disease might lead you towards a CHF patient, while a patient who worked in an area that had a lot of chemicals or dust might lead you towards a COPD patient. Consider their family history for a condition either way. Look at their medications. Drugs that increase the cardiac output, diuretics and potassium, might lead you towards CHF, while bronchodilators and steroids might lead you towards COPD. The story for the current illness will give you a lot of information. A patient who states that the complaint started while they were laying flat or at night, or that they just had a recent high sodium meal, they might be a patient who has CHF, while a patient whose symptoms were exacerbated by the humidity or environmental changes or after their last cigarette might lead you towards a COPD patient. In the end, you'll use this diagnosis as well as provider intuition to create your patient care plan until further testing can be done. And to quote my friend John Belinsky, if something doesn't seem right, trust your gut and don't carry that coffin by yourself. Consult somebody who can help you make that decision. I hope you can utilize this in your practice. Thanks for watching, and goodbye for now.